Very good afternoon to everybody, and welcome to this MedEClasses lecture series in which we'll be talking about growth hormone deficiency, which is one of the most common treatable condition that we encounter as pediatric endocrinologists. Unfortunately, most children who come to us with growth hormone deficiency come at a very late stage when the treatment may not be possible or may not be very effective. So what we'll try to do over the next 45 minutes or so is to try to focus about the various aspects in terms of diagnosis and management of growth hormone deficiency with particular emphasis on the guidelines which are there, as well as some practical information about how the newer forms of growth hormone may be of benefit from that perspective. And we will be trying to cover all those aspects from that regards. So why are we really concerned about growth hormone deficiency and what implications does it have in terms of our clinical practice? I'll start off with this case because diagnosis, of course, is most important. If you don't diagnose growth hormone deficiency at the right time, you will not be able to achieve the right diagnosis. So this was a 12-year-old girl who had a height of 120 centimeters and a weight of 15 kgs. Parents were of a normal height. And if you look at the chart, clearly we can see the child is below the chart, she is below the population, she is below the family. But what's more striking is that there is a predominant effect of the weight, which looks like a nutritional pattern of growth failure. However, the initial workup showed a normalish hemoglobin with a normal TSH and celiac profile. IGF-1 was low and a basal growth hormone was found to be low, based upon which the child was diagnosed as growth hormone deficiency. But if you really look at this overall patient profile, this is a scenario in which you have a predominant effect with regards to the weight. This makes endocrine cause less likely, and there is a need for consideration of a overall process. And here, growth hormone treatment did not do any benefit. When the child was referred to us, further evaluation showed us that this child actually did not have a growth hormone deficiency, had a IgA deficiency, which had a masked celiac on that regards. So clearly, before we talk about treatment, we need to really understand about how do we diagnose, assess, evaluate, and manage in that perspective. All of you can go and have a look at our website, learning.growthsociety.in, which has got a lot of resources related to pediatric endocrinology. We have got our learning portal, including YouTube, which has got over 600 videos with a large viewership across the globe. We run multiple courses which are validated with regards to pediatric endocrine learning, including fellowship courses, which are both hybrid online and offline model, as well as pediatric endocrine courses for postgraduates. We regularly run grand rounds, particular lecture series, as well as particular scenarios, lectures like these. We have got publication in the form of pediatric endocrinology protocols, basic pediatric endocrinology, and advanced pediatric endocrinology, which are available both in the hard bound fashion as well as the Kindle version on Amazon. And we've got a mobile application which helps in terms of evaluation and management. So I'll be focusing today predominantly in terms of how do we reach to a diagnosis of growth hormone deficiency, and then what would be the best way to treat from that regards, right from the initiation to the continuation, as well as the possibility of transition into the adulthood. We'll also touch base briefly about the newer advances, particularly the long-acting form of growth hormone from that perspective. So we all know that when you talk about short stature, growth hormone deficiency often comes to us as a major cause. But what we need to understand is that a vast majority of children who come to even pediatric endocrinologists like us do not have growth hormone deficiency. If we look by our own clinic figures, somebody whose height SDS is below -3, GHD will be like 10 to 20% of cases in that regards. If we talk about pediatricians and if we use a more liberal cutoff for short stature of -2, then 80% of these cases will be physiological. So the big dilemma that is there in the minds of any treating physician in terms of evaluation of a child with short stature is whether the evaluation is required or not, and we do not do unnecessary investigations in physiological causes, while we should not be missing the pathological cause. The key question is the child really short? If the child is short, is it physiological or pathological? If it's pathological, it's primary problem in the growth plate in the form of SGA, syndromes, and skeletal dysplasia, or it's a secondary scenario where it could be a nutritional or an endocrine cause. Now, how do we define short stature? And this is something which is often a cause of debate. Short stature is not like diabetes, wherein we can use glycemic cutoffs which are extrapolated with regards to long-term complications. So if you're somebody who has got diabetes, we know that if the sugar levels go above 127 for fasting or 200 for postprandial, or HbA1c are beyond 6.5, there are long-term impacts with regards to the cause and whether this child will have long-term implications on that. Height, on the other hand, it's very difficult to see what's the impact of short stature on long-term outcomes. Most people have used cutoffs which are based upon the population norm, so they would say less than third centile in that regard. So what would mean that every time, even if the whole population is growing, you will have 3% children who will always remain short. So what we tried to do was to look at what will be a better indicator of short stature. So we looked at the likelihood of pathology. And this gives us very, very good clues. So if the child's height SDS is above -2, only 2.5% will have a pathology. This figure increases by 15 times if we go between -2 to -3, and it becomes around 80% if the height SDS is below -3. So what it really implies is that if we have a very, very short child, height SDS which is below -3, the chances of pathology are significant and we need evaluation. So the criteria that we propose and often are similar to what other guidelines would propose is that if your height standard deviation score is more than -2, then nothing to worry, you give a green signal. If it's between -2 to -3, this is the time we need to be cautious. We may wait and watch, while if it is less than -3 standard deviation, definite evaluation is required. Now, what we need to understand is that standard deviation score is a better and a more objective criteria for growth retardation as compared to a percentile. If we say figure something like less than third centile or less than first centile, it doesn't tell you how short the particular child is. But if I know this is -2.2 or -4.4 SDS, I know there's a huge difference. The second thing to remember is that when we talk about height standard deviation score, this is not a linear phenomena. The chances of a child to have a height SDS of -3 is 40 times less as compared to somebody who has a height SDS of -2. So the implications, like if we talk about Richter scale, it's not a linear phenomena. It really tells us that there is a long-term impact in terms of the overall scenario from that perspective when we talk about short stature evaluation in that regard. So based upon this, if we now look into the growth chart, we go back, we don't really go back to SDS. So I would say SDS is something which is now easily available. If you don't go into that, go for the growth chart. If the child is very short, height is below the first percentile, you need immediate evaluation. On the other hand, if the child is short and not growing, that again would require evaluation. I would put that as -2 to -3 standard deviation score and a growth velocity which is less than -1 standard deviation score. In percentile terms, this would be like first to third centile and a growth velocity which is below the 25th percentile. And finally, if somebody is not growing at all, if there is a crossing of 2 or more percentile lines between the age of 2 years and puberty, this also requires evaluation. So somebody who is very short and not growing at all would require evaluation. I think this pretty much covers the specific aspect of what we really know and think about short stature. Now, once we know that this child is short, the next question is it a physiological or a pathological cause? And this is very important because while for pathologies, you would need multiple evaluation for physiological causes, which is like 80%, you may not need any evaluation. And in that regard, there are three things which will give you the clue, which include the growth chart, the pubertal status, and the bone age. The growth chart are, of course, the basis of any growth failure evaluation. We need to look at three things. How is the absolute status? What is the percentile, which basically tells you the deviation from the normalcy or the mean, and the standard deviation score, which I already talked about. The second thing is to look at how is the child compared to the parents. And here we can look into two aspects: target height, which we all know is the average of parental height, and you add 6.5 centimeters for boys, subtract 6.5 centimeters for girls, and add and subtract 1.5 SDS or around 6 centimeters to get the final target height. The other way to look at it is also target height standard deviation score. Generally speaking, a child should be within plus minus 1.5 SDS of the parent. So target height SDS, if it is uh, more than minus 1.5 beyond that the target height SDS, this would mean that the child is short. From that perspective, it's not a case of familial short stature. The third important thing to look at is what is more effective. It is nutritional or endocrine. The most important thing to look at in a short child is the weight, not the height. If the child has got a greater effect on weight, this indicates a nutritional cause. If there's a predominant effect on the height, this will represent that this is most likely a endocrine cause. And in our study, BMI standard deviation score emerged as an important tool. If the BMI standard deviation score is less than -1, indicating this is a nutritional cause, while the BMI standard deviation score is more than -1, this indicates a endocrine cause. So essentially, if you look at the height SDS, look at the target height SDS and the corrected height SDS and the BMI SDS, these three parameters, remember, will form the basis of how do we evaluate growth failure and reach towards growth hormone deficiency. Understanding the pubertal progression, of course, is very, very important. So we know that the girl evaluation, the most important point is stage 2, which is papilla elevation. And herein the growth spurt has started. From here, the child will have a growth spurt of around 2 to 2.5 years to achieve a height of approximately 20 centimeters. We should remember that we should not mistake lipomastia, which is because of fat, which is very common, to a true breast development, and therefore palpation becomes important. If there is true resistance when you're approximating your thumb and index finger around the areolar area, that will be indicative that you're dealing with something like a scenario of onset of puberty. Otherwise, this is most likely a lipomastia. Now, B4 or secondary mount formation is the stage when we are very close to menarche. This means that around the vaginal discharge is going to happen, and from here only 10 centimeter growth is there. Post menarchal, the growth is 5 to 8 centimeters. So whenever a girl comes to you with short stature, look at the pubertal status. If she is 135 centimeters and B2, she's going to land up around 155. If she is B4, she will land up at 145. And if she is menarchal, she will pretty much be 140. So always and always correlate with puberty. It tells you not only about the other causes, it also tells you about the likelihood potential to grow from that perspective. Boys, testicular volume, of course, is most important, and a volume more than 4 ml is the first sign of puberty. The spurt typically starts around a testicular volume of 10 ml, and subsequent to that, the growth is there. Change of voice or spermarchy are the most important signs which are equivalent to menarche in boys. Typical growth which happens during puberty is somewhere around 20 to 25 centimeters in boys and around 20 centimeters in girls, as we had discussed earlier. Now, very importantly, we'll try to go through some of the pubertal and the growth charts to see how we can be confused in diagnosing these disorders. So we have a 13-year-old boy who has a height which is below the third centile. If we compare to the population, the child is short. If we compare to the parents, he is also short. And if you look at this scenario, the height age and weight age are equally affected. So here, the second thing which will really tell us a lot about what the possible diagnosis is the bone age. And this bone age was sent to a radiologist who reported it as 14 years. Now, this is a make or break issue. If this child is short, his bone age is 14 years, which means he has got very limited time to grow. Maximum growth occurs till around 16 years of bone age in boys and 14 years of bone age in girls. And after that, only 1% growth is left. So if you look by this picture, we are talking about a very, very compromised height. But is this bone age really 14 years as reported? And that's a big dilemma that many pediatricians particularly face where radiologist reports may not corroborate with the actual bone age. So if the bone age is 14 years, growth hormone treatment is required definitely. But when we reassess clinically, this was not 14, it was only 10.5 years. And there was clearly no need for treatment from that regards and follow up because this is most likely just below the third centile fitting into a delayed bone age, delayed puberty, going into a constitutional delay of puberty and growth. So, as along with the pubertal status, bone age is also a very, very important tool to look at in that regard. There are standard tools available for bone age assessment, including the Grulich Pine Atlas, in which you compare each part of the bone with a particular image which is available. The problem is that sometimes the carpal bones may tell you differently, while the phalanges may tell you differently, and you cannot really match each of these together. To overcome this, Tanner Whitehouse brought up a wonderful idea where they have 20 regions of interest in which you rate every region of interest separately, because there could be discrepancy in terms of growth of different regions. The problem here, of course, is that this brings in better accuracy, less inter-individual variability, but what is going to bring in, of course, is more time consumption. It may take up to 15-20 minutes also for a non-expert user to assess a Tanner Whitehouse. This led to the development of an automated tool like Bone Expert, unfortunately, which is at a reasonably high cost in that regard. So what we want is a simple way to assess bone age, which can be readily done by non-experts, provide immediate information which is validated against gold standard. So what we did was that we developed and validated a novel mobile application for bone age assessment. The first things we wanted to do was to cut down the number of sites for bone age assessment. So from 20 of Tanner Whitehouse, we cut it down to 5 sites, which basically are the middle finger middle phalanx, middle finger proximal phalanx, the thumb, the radius, and the ulna. And these 5 sites provide a very good correlation with a complete 20-site Tanner Whitehouse assessment. And in fact, if you want to be more even single site middle phalanx could give you a good information from that regards. Once we had developed that, we loaded it in our application, wherein all you have to do is to compare the bone ages at different parts to the region of interest, and only 5 sites have to be looked into. And once these 5 sites are matched, we get results quickly in terms of the likely bone age along with the bone age range. And this is something which has been clearly validated for both expert users and non-expert users, and it provides quick information in around 2 minutes. Even for a non-expert user, provides a result like this, and this has got good Bland-Altman plot in terms of the difference from that perspective. So MedEClasses bone age application, you have to just select a particular site, compare that to 5 different regions, and you will get a bone age in that regard. So bone age, growth chart, and puberty, these three will tell you this is physiological versus pathological. Now, once we know this is pathological, the next question is the problem in the growth plate or is the problem in the environment? And clearly, the primary causes can be identified. You can get a history of small for gestational age. You can get other information. So before that, if your corrected height SDS is more than minus 1.5, this is basically a familial short stature. If the child is not short for bone age, that is the height SDS for bone age is more than -2, this will indicate this is constitutional delay of puberty and growth. And then for primary, look at the birth weight, look at the facies. If there is facial asymmetry, if there is triangular facies, this could be Russell-Silver syndrome. Look at the body proportion to identify skeletal dysplasia from that regards. Often, where we are stuck is to differentiate nutritional versus endocrine. And here, as I said, the weight is most important part of evaluation of a child with growth disorder. If you have a growth child like this, the first case which we discussed, who has got more weight affected, or in simple terms, if the BMI SDS is less than -1, this is likely to be a nutritional cause. While on the right hand side, if you see the height is more affected, the BMI is preserved, the height is more affected, this is more likely to be an endocrine cause. Endocrine causes are rare, but if you have a short and plump child, think of hypothyroidism, growth hormone deficiency, pseudohypoparathyroidism, Prader-Willi syndrome, and Turner syndrome as the clinical possibilities which become important from that regards. So now we've talked about the clinical parameter, and by now, by using the growth chart, the bone age, simple physical examination and puberty, you will be able to classify. And now you decide about what test to do. So as I said, for physiology, CDGP was familial, we can look at growth chart, puberty, and bone age, which will give you the clue. For pathological causes, facies and body proportion will give you an idea. Birth weight will give you an idea about SGA. Definitely any girl who is short, and once we have excluded all the other possible causes, chromosome analysis becomes important. And we are talking about 20 to 30 metaphase to identify that. And genetic analysis is also now becoming important for SGA. Skeletal dysplasia, we need to get a complete skeletal survey to get the diagnosis. Nutritional causes, we have to look at liver, kidney, blood gas analysis, and fecal calprotectin for inflammatory bowel disease. Thyroid profile is absolutely essential across all causes of short stature, and growth hormone stimulation should be done in particular cases. So before we really go ahead with growth hormone stimulation, we have to really tick all our boxes. Otherwise, you will have a false report. So everybody should have a CBC, a liver, and a kidney function, along with celiac profile, thyroid profile, irrespective of the nutritional status. The tests which may be needed include karyotype in girls, blood gas below 3 years to identify RTA. It's unusual for renal tubular acidosis to present with isolated growth failure beyond 3 years of age, and fecal calprotectin above 10 years to identify inflammatory bowel disease becomes important. Remember, we should do growth hormone and IGF-1 evaluation only after all the other causes have been ruled out from that regard. So this is the approach we use in our algorithm. The three primary question is the child short? If the height SDS is above -2, no workup. If the child is short, the next question is the child short for the family? If the corrected height SDS is more than -5, again no workup. If the child is short for the population in the family, is the child short for the bone age? Yes, then we need to do workup. Otherwise, this is CDGP. So these three will be around 80 to 85% of all cases. If the height SDS is below -3, however, we don't need to worry. We need to do start workup right away. In children between -2 to -3, we should think of systemic disorder screening, which includes, as we discussed, CBC, ALT, creatinine, electrolytes, TTG, thyroid, sugars, and all those scenarios, and blood gas before 3 years of age. If all of them are normal and then follow up shows a low growth velocity, we should start thinking of some specific causes like excluding IgA deficiency in celiac disease and karyotype in girls. If everything is normal, then only we do a growth hormone IGF-1 evaluation from that perspective. So a systematic approach becomes absolutely essential. So how do we look at, and now we come back to our own original question, when should we be having a high index of suspicion for growth hormone deficiency? If you have severe growth failure with other features like pot belly, micropenis, undescended testis, midfacial hypoplasia, immature doll-like faces, as discussed, if there is a central adiposity, hypoglycemia in the newborn period may be the only clue to a hypo multiple pituitary hormone deficiency, or for that matter, a possibility of isolated GHD in rare cases. Undescended testes and cholestasis could also be other parameters to look at. Now, very importantly, assessment for growth hormone IGF-1 axis should be done only after exclusion of all other possible causes, and once we have ensured that the child is euthyroid and has a normal cortisol axis, no features of Cushing syndrome. The options include to do growth hormone, but never do a basal growth hormone, because basal growth hormone has got a lot of fluctuations. It's a pulsatile hormone. The options include insulin, glucagon, and clonidine. Recently, masomerilin, which is a ghrelin agonist, has also been advised as an agent which can be considered in terms of growth hormone stimulation in adults. It's not been approved in children. The benefit of that is that it has only effect on growth hormone and other effects are not there. Insulin and glucagon are associated with a rapid fall of glucose. One is the initial response, while for glucagon, which is a rebound hypoglycemia, and this rapid fall triggers the secretion of growth hormone. Clonidine is a centrally acting drug which is going to work through the neurotransmitter pathway. These are the gold standard tests, but remember, these tests are not perfect. So if we do them in somebody who has got a low pretest probability for growth hormone deficiency, they would not be very reliable. So do not do unnecessarily growth hormone stimulation test in somebody who doesn't have a high chance of growth hormone deficiency. 10 to 20% normal children will fail growth hormone testing if we do not if we do that without screening from that regards. Now, very importantly, cortisol has an impact on GHRH, growth hormone, IGF-1, so cortisol should not be high. And thyroid also has an impact in terms of the entire growth hormone axis, so that also should not be affected in that regard. A very important factor to remember is that the response to growth hormone in the peripubertal age group is modulated by the impact of sex hormones. So, estrogen, both in girls and boys, directly coming from the ovaries in girls and by aromatizing the peripheral testosterone, stimulates the growth hormone secretion. So, individuals who have delayed puberty, who are not being primed with estrogen or testosterone, may not respond that well to growth hormone, resulting in a false diagnosis of growth hormone deficiency. Therefore, role of sex hormone priming is indicated in girls who are beyond 10 years and boys who are above 11 years who do not have clinical features of pubertal onset and who are within the target height range when we predict them. So it's not indicated for somebody who is extremely short, not indicated for somebody who is less than 10 years in girls and 11 years in boys, or already who has pubertal onset. In other scenarios, this priming becomes important and this will help avoid the unnecessary diagnosis of growth hormone deficiency. The screening tests that we look at include the IGF-1, which is a growth hormone dependent peptide. But remember, IGF-1 is age dependent, it is nutrition dependent, it is produced by liver. So there are a lot of confounding factors which are there. There is limited data with regards to the IGF-1 status across most countries. Recently, the data has been published from India, but we need larger studies to get a proper information in that regard. Very importantly, obesity has a significant impact on the growth hormone axis. With obesity, if your insulin levels are high, you will have suppression of the IGF-BP production, resulting in increase in free IGF-1 and decrease in growth hormone. So obesity may cause low levels of growth hormone in adults. There are different criteria which are there for BMI adjustment as far as the diagnosis of GHD is concerned. This has not been yet recommended in children, but many people consider that we need to be cautious in obese individuals who are marginally short and who have a marginally low level of growth hormone. Similarly, if somebody is undernourished, the IGF-1 level will be low while growth hormone can be high. So this again needs to be considered. Liver disease, of course, has an impact on IGF-1. IGF-BP is another parameter which is relatively age independent. So if you're looking at age below 2 years, IGF-BP may be a good marker of growth hormone action, but it's not that significant in terms of the routine use in clinical practice. So just to summarize what I discussed about IGF-1, this is the curve. We see a significant increase with age and with puberty. So below around 5 years, this is of limited role. And you can see around puberty, there is a huge difference. So again, it's difficult to interpret how that level is of a particular individual depending upon the pubertal status. So it's age dependent, nutrition dependent, and this is something which we need to be cautious about. IGF-BP3 shows a very gradual increase, so it can be used in younger children. It's age independent with no nutritional effect, so this could be a theoretically a better idea in terms of growth hormone evaluation. Having said that, we need to remember that growth hormone dependent peptides, that is growth hormone and IGF-1, both are essentially screening tests for growth hormone deficiency, and the final diagnosis is established using the growth hormone stimulation test, which should be done carefully to identify the particular cause to achieve the particular diagnosis. The test is ideally done in the morning in a fasting state after priming in individuals who are 10 years and above in girls and 11 in boys who are prepubertal. We can use ethinyl estradiol in both genders and testosterone 100 milligrams given 1 week prior to the test for boys. Stimulus, we can use clonidine, insulin, or glucagon. Insulin and glucagon should be carefully monitored because there is a risk of hypoglycemia. Many centers use clonidine where blood pressure monitoring is important. So, according to the Pediatric Endocrine Society guideline of around 215, levels less than 5 suggest complete GHD, 5 to 10 is partial GHD, and more than 10 is considered normal. The GRS Society guidelines of 2019 have revised the criteria to 7 nanogram per ml. So most pediatric endocrinologists are comfortable with 7 rather than 5. What we need to, however, remember that these figures are arbitrary. They are not based on any large scale data. And if you talk about true GHD, the levels will be very low. In fact, less than 3, which are the adult cutoff, and in most cases, less than 1. So the cutoffs are in a way a marker of growth hormone responsiveness. Lower the growth hormone, higher the responsiveness. We are already talking about treatment for idiopathic short stature. So if somebody is very short and growth hormone is marginal, we may consider growth hormone treatment in that perspective. These tests are not perfect. They are not gold standards. Their cutoffs, as I said, are arbitrary. They are not really set up based upon response. These tests show a lot of intra and inter-test variability. So if you do the same test, same time, two tests, they will show different variations. If you do the test now and after 15 days, there may be variation which is there. And final height correlations are limited. There is also a overlap. 10 to 20%, as I said, normal individuals, quote unquote, whose height is normal, will show a growth hormone deficiency on a test, and therefore pre-test probability becomes absolutely important. The test, as I said, is also confounded by the effects of puberty and obesity, which has got a huge implication in that regard. So these tests should be done only when indicated. Best is to do two tests to make a confirmation, especially if the pre-test probability is low. And if, however, a patient has got multiple pituitary hormone deficiency, CNS insult, radiotherapy, MRI finding, then IGF-1 is low, we may avoid doing these growth hormone stimulation tests. The guideline by the Pediatric Endocrine Society of 2015 lays large focus on oxology. So height should be less than -3 or less than minus between -2 to -3 and growth velocity below -1. They do lay emphasis on growth hormone stimulation and use 5 as the cutoff and 10 as normal. Low IGF-1, as I said, if there is associated malformation, insult, imaging abnormalities or tumor, that is where the problems can be considered on. So we have a 12-year-old girl, height is 120, weight is 15. This is something which we already discussed. This is a case wherein we had misdiagnosed a case of nutritional cause because of low IGF-1. Remember, IGF-1 will be low in malnutrition, so it should not have been considered. The clinical pattern is nutritional. Here, a IgA level gave us a diagnosis. When we really looked into as to how common these problems are happening in terms of clinical practice, what we found that there was a large discordance. We shared 250 case scenarios, including bone age, X-rays, pubertal status, and many parameters with experts, pediatricians, and trainee. And what we found that there was a large level of discordance which were happening at all level, particularly at the trainee and the pediatrician level. And these were both acts of omission, wherein tests were not done when needed, and acts of commission, where tests were recommended when not needed. So this is something which is common, resulting in missed pathology, overdiagnosis of pathology, and misclassification. So we have tried to develop tools which can help us reduce these problems. And this includes the development of a mobile application, which tried to develop is the growth interpreter, in which you have to put some basic inputs about the height, weight, the bone age, the parental height, and it will interpret and give the results with a high degree of concordance from that perspective. So your 12-year-old girl, a similar scenario as we were discussing earlier, if we put those data in our growth interpreter, it will say likely nutritional pattern. So there would be no diagnosis of growth hormone deficiency from that perspective because the BMI SDS is less, and this will guide us towards the correct diagnosis from that regards. Now we have another case scenario, again labeled as GHD. So this is a boy who is just below the growth chart. And if you look at it, the bone age is slightly delayed at around 11 years. The height age and the weight age is 9.5 years. The peak growth hormone was low. All the other workup was done. So by the time the child was referred to us, he was labeled as growth hormone deficiency, referred for treatment. But if we look at the child carefully, this child is just below the chart. 99.9% of such scenarios who are prepubertal with delayed bone age, which is mildly short, are constitutional delay of puberty and growth. So the first question which we asked from the family and the referring physician is whether this growth hormone testing was after a priming or not, which was not done in this case. So this is the ideal scenario. Child, a boy who is above 11 years of age, has height which is within the target height range if we project it from the bone age, has no puberty. Here priming becomes absolutely important. So if you go back into our put all the data there, it's talking about the possibility that this is most likely constitutional delay of puberty and growth. If you want, you can just follow up. If you want to do a growth hormone testing, do it after priming. That is something which is absolutely essential. Another scenario, a 8-year-old boy who is short and the parents of normal height, and what we are seeing here, this is a child who is very, very short. Because of this TTG of 32, which is normal value of 20, he was labeled as a case of celiac disease and advised gluten-free diet. But if we look at the clinical response, there was no response to gluten-free diet. This child, if you look at the clinical scenario, is much, much shorter than compared to his weight. And if you put the data here, what we see is that this child apologies for the technical glitch. So we're discussing about how the interpretation of growth would be of help in terms of giving a rational approach of evaluation of growth, pubertal, and obesity related disorders, including guidance for both growth as well as puberty and around follow up tracking from that regards. We have shown that this tool has a very high concordance rate with regards to the growth hormone, with overall growth and pubertal disorder, and will improve the overall concordance, which was seen according to pediatricians and pediatric training by the tune of 96%. So this tool is going to help us reach the diagnosis of growth hormone deficiency and other disorders at an early age to identify the correct diagnosis. And we spend a lot of time in terms of diagnosis because diagnosis is very important. If we start growth hormone without the right diagnosis, we may be doing injustice because we are not having an appropriate response. We are unnecessarily producing somebody with side effects. So what are the options we can use for growth promotion? We can use growth hormone, which acts largely not only through the liver to increase the growth hormone receptor producing IGF-1, which again impacts the growth plate. It also has a direct effect on the growth plate, endocrine and a paracrine effect as well. The other way, of course, is to really look at the overall impact of improving growth, is to delay the epiphyseal fusion by inhibiting the estrogen level using either a GnRH analog, which will suppress puberty in both boys and girls, or use aromatase inhibitors in boys, which will provide further growth. Another parameter which has recently been launched is a C-type natriuretic factor related peptide, which will be there. So the options are either to increase the rate of growth using growth hormone or IGF-1, or we can delay the rate of fusion by using a GnRH analog or a aromatase inhibitor. Now, growth hormone treatment is clearly the treatment of choice in growth hormone deficiency because compared to IGF-1, it gives us a better response. It does not give rise to hypoglycemia. It does not give rise to an elevation of IGF-1 to a great level. So, if you have growth hormone deficiency, growth hormone is the treatment of choice. IGF-1 treatment is only indicated for a genetically proven growth hormone insensitivity, or if there is a growth hormone deficiency variant wherein giving growth hormone has caused antibodies to be formed, and that can have implications in terms of growth hormone responsiveness. So that's the only scenario where IGF-1 is actually approved in terms of use. Now, growth hormone is available across board and it's being used for around 70 years. Earlier, it was pituitary derived, but because of the prion mediated Creutzfeldt-Jakob disease, 1984, thankfully, there was the recombinant growth hormone which was available, and subsequently it's being used across indications. So indications are broadening, including chronic kidney disease, Turner syndrome, and then we have the long-acting GH, which was the original one, which was more painful, had more swelling, and then subsequently we had other indications opening up, including Prader-Willi syndrome, SGA, and clearly ISS. So now the overall expansion has happened in terms of treatment. I'll largely be focusing with regards to growth hormone deficiency because that's the agenda for today. And I will also be focusing predominantly on induced. We remember that growth hormone does different roles at different ages. So the levels are low in fetal period, they increase in childhood, reach a second increase, particularly during puberty, where we see a huge increase. They then come down, and during senescence, we have got a lower level of growth hormone, which is there. The typical production rate of growth hormone in children is around 25 microgram per kg per day, which basically increases during puberty to around 35 to 45 microgram per kg per day. And this is the time when growth hormone is working. The major impact of growth hormone is during the childhood and the puberty phase, particularly during childhood. So if you're diagnosing somebody late with growth hormone deficiency, you would have implications in terms of height outcome. Subsequent to that, it also has an impact on bone, which happens till around 25 years of age. And there the requirement will be like 25 microgram per kg per day. And finally, it has got beneficial effects on cardiovascular health and quality of life by the effect on adipocyte, where the requirement will be less. And after somatopause, typically the dose will be much less. The typical dose that will be there around anti-aging will be much lower from that regards. Growth hormone is available in the form of biological compounds which require much more evaluation and testing when we start using them in a market. These are compounds which are derived, so they are biosimilar compounds, need to have a lot of evaluation and impact there. The biosimilar compounds, however, have advantage of lower cost in terms of growth hormone therapy. So as discussed, it's used in GHD, Turner's, SGA, CKD, Prader-Willi, and ISS. I'll be focusing predominantly on growth hormone deficiency. There are other indications which are emerging from that regards. So the Pediatric Endocrine Society guidelines, as we discussed, talks about oxology as a primary criteria with the need for growth hormone stimulation test and low IGF-1 also in a similar scenario. So the major emphasis is the most important thing which decides treatment is the height, and that should be a primary motive from that perspective, and that will be really able to tell us the need. Very importantly, before we start growth hormone, we should ensure that the pituitary function is normal. There should be a normal free T4, normal cortisol, because growth hormone is going to increase the metabolism of both cortisol and thyroxine, precipitating hypothyroidism and cortisol insufficiency in that regards. Neuroimaging is absolutely essential because we do not want to miss a CNS lesion and start growth hormone, because growth hormone can be given at least 1 year after final treatment of a neoplasm like a craniopharyngioma. Very importantly, we should look at contraindications for growth hormone like Bloom's, Downs, and Fanconi syndrome, which may be present in that regards. And as discussed, we have to wait for at least 1 year after treatment of malignancy. In multiple pituitary hormone deficiency, careful dosing is essential. So acetate deficiency, we don't want to give too much hydrocortisone because that is going to suppress. So typically 6 to 8 or up to 10 milligram per meter square per day of hydrocortisone should be used. Do not use prednisolone or dexamethasone, which are growth suppressing. For TSH deficiency, thyroxine, and again try to maintain the FT4 in the high normal range. Gonadotropin deficiency treatment should be age appropriate, so around 12 years in girls, around 13-14 years in boys would be a right time, and we can use multiple agents in terms of treatment. The dose, as I discussed, is based upon the clinical dose production. So in childhood, typically we'll be using 25 microgram per kg. Puberty, the dose may be increased, but the guidelines do not suggest a blanket increase in everybody. In adults till 25 years of age, we can use 25 microgram per kg per day. Men, the dose is around 200, and women need more dose because of the estrogen effect on the liver of 300 microgram per day. Elderly, the dose is only 100. Very importantly, in somebody who has got a severe growth hormone deficiency, start with a lower dose because giving too much dose may cause problems. And somebody with mild, we may need to start off with a higher dose. At puberty, there may be a need to increase the dose, especially if the child is short at that point of time. However, there is no routine recommendation to increase the dose in everybody around puberty. Now, studies have clearly shown that depending upon the catch-up response, we can then decide about how to go about in terms of treatment. And this catch-up in the initial phase is a good predictor of long-term response. We should look at height, which is expected to increase by around 10 to 12 centimeters in the first year and then 8 to 10 centimeters subsequently. We expect a height SDS increase of more than 1.5 in 2 years. If it's less than 0.5 in 1 year, that's a cause of concern. The Growth Hormone Research Society has clearly talked about this. If the height velocity SDS is below 0, height SDS is less than 0.3 per year, and height velocity less than 2 centimeters per year, we have to worry. Look at bone age. There is some bone age advancement, but it should not be inappropriate. Also, look at IGF-1. The levels should be within +2 standard deviations. So while we want a response, we don't want the IGF-1 to go sky high from that perspective. There have been studies which have tried to look at whether titrating the dose of growth hormone as far as IGF-1 would result in better outcome, like we do it for thyroid or we do it for other hormones. The problem here is that the dose requirement may be very, very high and the height increase may not be huge. So the guidelines do not recommend IGF-1 based dosing. The main reason why we are doing IGF-1 is to prevent any toxicity which is happening. Lower the level of growth hormone, greater the height of the parents, higher the dose, earlier the treatment, the better is the response. Now, if we start treatment at an early age, we are not only giving lesser dose because it's weight dependent, we are also getting good response. That makes early identification of growth hormone deficiency absolutely essential. If a child is not responding, think of other conditions like celiac disease, hypothyroidism, look at nutritional. Growth hormone treatment may unmask central hypothyroidism, which we have to evaluate for, check for adherence, the technique, and whether growth hormone antibodies have been formed in GHD 1B in that regard. So we have a 10-year-old child with short stature whose peak growth hormone is 0.1, very, very low. The child is extremely short, started with growth hormone, good initial response, but subsequently the growth velocity is less. This is a classical case of GHD1 in which you have got no exposure to growth hormone to begin with. And now once we give growth hormone, there are antibodies which are being formed, resulting in decreased response. The only possible treatment in this scenario would be to use IGF-1 as therapy. 13-year-old boy with GHD on GH, there is a good response with a reasonable dose. Now the child has entered puberty and is still short. So what can we do to improve the height from here? So in this scenario, the options could be, as I discussed, is to either delay the puberty using a GnRH analog or aromatase inhibitor to delay the epiphyseal fusion, or we increase the dose of growth hormone. So these are the three options which are available. All of these are experimental, so they should be done after detailed discussion with the family and see how much the height would be improved from that regards. So pubertal management, as I said, you can use higher dose. 50 is the recommended dose. You can go up to 50 microgram per kg per day, or use GnRH analog or aromatase inhibitor to increase the duration of growth. The guidelines clearly say that there is no routine role of increasing the dose, but it can be done on an individualized basis. The adverse effects, it's a very safe therapy. Growth hormone is one of the most safest therapy if given in the right dose, in the right individual. Some people will develop edema because of protein retention. This is a reversible phenomena. Benign intracranial hypertension occurs in 1 in 500 cases. There may be unmasking of hypothyroidism. So monitor thyroid at 3 months, 6 months, and 12 months. Very important side effect to remember is slipped capital femoral epiphysis, which is not just the effect of growth hormone, it's the effect of rapid growth. So if a child grows rapidly, the epiphysis may slip. This will present to you with somebody who was normal, suddenly starts limping, has pain in the knee, pain in the hip. This is something important to identify. Dysglycemia, absolutely uncommon in growth hormone deficiency, more common in Turner's or SGA. And tumorigenesis is an important factor. It's very safe, but we need to understand that there are some studies which needs to be evaluated. The major reason why many people talk about the effect of growth hormone on tumorigenesis is the association of high IGF-1 with tumorigenesis, especially with acromegaly. What we need to remember is that when we treat with growth hormone, we are not only increasing IGF-1, but we are also increasing the IGF binding protein. Therefore, the free IGF-1 rise is not that much, and the risk of malignancy theoretically is not there. There are large databases which have looked into these factors, and they know that there is no effect on the primary cancer. Recurrence is also not increased. The only thing which has been shown to have some increment is the development of the second tumor, which may happen slightly early. This is the large database, a European study which we looked into and was found to be a bit safe from that perspective. There is some theoretical concern about meningioma. And again, the authors have said that there is a meningioma risk with cranial radiotherapy, and GH may not affect the risk. So the effect that we are seeing is more about the effect of radiotherapy rather than that of growth hormone. So this is something which we need to really remember. Now, many people ask, once our treatment is over and height is over, what do we do? Whether we need to treat them or not. The thing to remember is that growth hormone also has the effect on bone, especially till 25 years. So the United Kingdom guidelines do talk about the treatment till 25 years. Adipocyte, you can use it for adult growth hormone deficiency, and then you can consider from that regards. If you're talking about only growth, bone age of 14 to 16 years for girls and boys, this time when the height will fuse and the growth velocity is less. Bone, we can give it to 25 years. And for adipocyte, we need to do a retesting in adults and use a cutoff of 3 nanogram per ml, especially after an insulin or an arginine test. Transition should be done only if there is after a washout period of a month. No testing is required in somebody who has got a multiple pituitary hormone deficiency, imaging issue, or CNS insult. The test is insulin or glucagon with levels less than 3 in that regard. For adult GHD, the treatment is mainly for the bone health, quality of life, and cardiac risk. The diagnosis should be reconfirmed, and the dose is for young male 200, young female 300, and for older individuals it is 100 microgram per day. From that perspective, I'll just run through the guidelines from the GRS Society 2019, and they really talked about very important factors which I already highlighted to, is that IGF-1 based dosing is something which they do not recommend. The routine recommendation for pubertal increment is not there, and they recommend that if the growth velocity of 2 to 2.5 centimeters per year is the time when you should stop growth hormone in that regards. And very importantly, for somebody who has an ongoing tumor, a gap of 12 months is what is recommended. There are prediction algorithms which can guide us in terms of growth hormone dosing. IGF-1 should be 0 SDS, not above plus 2 SDS definitely. And if somebody's height velocity is below 2 centimeters per year, that's a major cause of concern, and you have to reevaluate for other possible causes in that regards. Now, what's new? Every time somebody comes to us with growth hormone deficiency, the question of the parent and the child is, how long do I need to give the treatment? And this injection daily is difficult. So the newer options include the long-acting weekly preparations, which have been there for quite some time, but have now been developed using a newer mechanism. Inhaled growth hormone, still experimental, and the role of secretagogues like methimorelin is again experimental. So largely we're talking about long-acting growth hormone, which is weekly growth hormone, which will help with regards to achieving height without the need of daily injections. The The two major ones which are available are somapacitan, which has basically been developed by increasing the binding of growth hormone to albumin. It's been used across indications, not yet approved in India. And the other one is somatogron, in which the growth hormone is bound to a HCG moiety to prolong the duration of effect. Again, this has been shown to have a similar effect as compared to the daily growth hormone, and this is now readily used in India from that perspective. So we have tried to cover the entirety of growth hormone deficiency, right from short stature evaluation to confirmation of diagnosis to evaluation and to management, with a brief overview about the various aspects of evaluation. All of you can go and have a look at our books, the protocol book, the basic and the advanced pediatric endocrinology, our application which can help assess in that regards, and our courses on our website in that perspective. So at that point of time, I will close this session and see if there are any particular questions which are there. So you can feel free to post the questions. So if there are no questions, we'll close this session, and we'll be posting this on our website as well as in YouTube, and you can look at those resources which are available there. Thank you once again for joining on.